Good morning and welcome to our monthly webcast. This is session number 41. I am Samir Mehta, your moderator, and you are going to witness another truly and genuinely complex coronary intervention. It's a CTO case today, and with all our deep sense of humility, we have found somebody who's even a better expert at this than us. So, joining in the cath lab today is world's top CTO expert, somebody who I came to understand and I told him has absolutely no life. He does 300 CTOs a year, and delighted to welcome Dr. Craig Thompson. Craig is the Chief of Interventional Cardiology and Director of the Cardiac Catheterization Laboratory at Yale School of Medicine. Craig, good morning and welcome, and thank you for coming. Is that exactly right? 300 CTOs a year. Do you have a family?
I do. Wonderful family. I get to see them as well.
It's a joy having you here. We'll use all your skills and wisdom to enlighten both us as well as the audience. Samin, good morning. Another tough case you've selected. One of the thoughts I have is CTO is a planned procedure where you put away everything else, and we increase the challenge by trying to do it in 60 minutes.
That is absolutely correct. Actually, as you saw, a lot of feedback on our website with the ACC, and earlier it used to be heart.org. The people have said that we are really taught quite a bit globally, the rotational atherectomy, the bifurcation, and so they need to have two areas which need more expertise, technique point of view need to learn, and two are, one is the thrombotic lesions and second is the bifurcation, the CTOs. So those are the two, and of course thrombotic is not that common, vein graft or so, because acute MIs very little at Mount Sinai. That people will be surprised that we get maximum 2 STEMI in 30 days. 2 is the maximum in Mount Sinai ever in a month.
That is exactly what I do between 1 and 5 each night.
Yeah.
Samin, last time we gave a teaser, we had just announced that there was some data from the New York State about the quality of the cardiac catheterization and their volume. You have more data for us?
Yep, actually the last time when we said the report just came out, and if we put our slides and you see, and of course I welcome all our global audience from Mount Sinai Cath Lab, and we, of course Anu will be doing this case, and left side, right side is my fellow with a long name, we call him Bernie, but the key, and then my rest of the Cath Lab staff. You see this, as you know, New York State publishes the risk adjusted mortality of all PCI cases, whether it's unstable hemodynamically or so, but follow up all the cases with the 30-day, and you can see here the data came, usually they are 1.5 years behind because you have to have a mortality index, and this is the data for 2008 to 2010 with the all cases, non-emergency cases and emergency cases. As shown below, that if your risk adjusted mortality is higher than average, then you get single star, which is a bad thing, and if you get double star means lower than average. And this is where Sinai for since 2002 have received double star in one, if not more than one category. Actually, as you saw last year, we got in all 3 categories. This year only in 2, all cases and non-emergency cases. Particularly emergency cases, as I said, are much smaller, less number, but clearly this information is available on the New York State Health website. But very important, very powerful message to the community that complex cases, if you do it right, you will really climb up the chart. And the volume, you can see here that clearly with a big margin compared to any other center, and we continue to enjoy the great, more patients and with a better outcome. The second is just for the 2010 data, same thing, that about 2,800 difference with the second center, with a very low non-emergency cases with the 0.36 and the emergency cases with the 2.55, with overall is more than 3% for the state. With that note, I really, this is all, people ask that we are about 10, 12 full to part-time cardiologists, and then we have another 8, 9 voluntary interventionalists. How do we keep this consistently, these results? Part of, we say that it's a system protocol, and that is what I take a pride in, and myself and Anu teaching everyone, whether it's a fellow, nurse practitioner, nurses, and other staff and other attendings, so that all talking about and doing the procedure in the similar way and get the consistently great results.
Samin, congratulations. Clearly this is a team effort, and I know there are so many people who are involved in making this happen. Three quick housekeeping matters to tell you. You can always go and listen to all our archived sessions. We have also introduced an audio only portion if some of you want to watch it or hear it instead of the Beatles. And of course, please go to the Chinese simulcast on the screen, just press it, and we welcome the physicians in mainland China. Ni hao, and welcome to the monthly webcast. Samin, you're going to take us through the case for this morning?
Absolutely. We are ready, and this is a 43-year-old male who presented about 2 months ago with non-STEMI, very small, peak troponin of 0.8, has EKG changes, and cath revealed 2 vessel CAD and normal LV function. That time LAD was the culprit. Patient got a zotarolimus-eluting stent of proximal LAD and cutting balloon PTCA to the diagonal, did fine, did have some angina, and because of continued angina, we did a stress test and he has an inferolateral ischemia. And he is on otherwise good medical therapy which patient should be on. And we'll show the angiogram, the 2 vessel disease of the LAD diagonal and CTO of the right coronary artery. And as I said, we will do in next 3-4 months more CTO cases. After the initial PCI, patient has done fine except angina, and now Anu will take us through. Anu, tell us.
Yeah, this is his, if you see here, non-obstructive large circumflex, but here is his LAD, the stent looks okay, and then.
Did you lose, there is a small diagonal up there?
No, yeah, that was the way it was, not
right.
Lost by us.
Okay.
Yeah. And good LV
function, yeah.
Yep. And here is the vessel.
RCA.
Samin, let me bring in Craig here. Craig, the way I look at it, the most critical part of a CTO is evaluating the angiograms. So as you look at it, tell me what all comes to your mind and what kind of a strategy would you consider?
Sure. I typically view these CTOs in the context of a construct we call the hybrid algorithm or hybrid strategy, meaning that we try to harmonize wire-based strategies, dissection reentry tools, both in the antegrade and retrograde direction. And really there are 4 parameters primarily that I look at to gauge initial strategy, and then provisional strategy should we go into failure mode. And it's how clear is the proximal cap? Is there proximal cap ambiguity? In this circumstance, I think we really know where the CTO starts. There's this long stretch of disease, there's a proximal cap in the distal part of the vessel, but it's not a lot of guesswork to understand how to get antegrade equipment in there. So clarity of the proximal cap either by angio or IVUS. Second is lesion length. Lesions that are over 20 millimeters, we know from a variety of registries. Oftentimes that's where we go into failure mode with conventional wire-based strategies and certainly sacrifice procedure time and efficiency. Third is quality of the distal target, either for re-entry methods or for simple wiring. How diffusely diseased is it, how well is it visualized? And then finally, the suitability of interventional collaterals, meaning that all of these are going to have some degree of collateral sourcing, but some either from a difficulty perspective or from a safety perspective are not suitable to use as an interventional tool for retrograde techniques. So as we visualize this case, I see a lesion that's probably longer than 20. It's certainly in this cusp of where wiring could be difficult. The proximal and distal caps, the proximal cap is fine, the distal target's great, so in that sense it's very good for antegrade type strategies. And in the interventional collaterals, though they're epicardial with experience in retrograde are suitable. There are collaterals, there's this large epicardial from the circumflex that you see, rather tortuous, and there's actually a right-to-right collateral, this Kugel's collateral, that could be used. These septals in this circumstance is really not a true PDA in this right coronary, and these seem to be just feeding into an acute marginal, and I think that would be a blind alley and not useful for retrograde. So in my mind, this is the only reason that I wouldn't start in the antegrade direction is how importantly I view this first branch that comes off of the right coronary artery. Because in some likelihood we may dissect past it, in which case that's fine, we can re-enter or wire it, but we may want to rescue that branch at the end depending on how important we feel that it is with respect to myocardial reserve. So for me, the indicators would be 2 catheters, and I probably would go retrograde to start from the AV groove circ. If that didn't progress very quickly, then I would probably convert to antegrade techniques with the idea that if I can't get true lumen, I would re-enter probably in this nice target beyond that branch and then just rescue the branch provisionally.
I'm sure as the case progresses, we'll continue to explore different options. A quick initial question for you. Are you trying to get a multi-slice CT for these CTOs?
I'm not. I flirted with CT a bit several years ago, helping work with a company called Sheena Medical that's based in the Tel Aviv biotech sector for co-registration technologies. But we've had such difficulty in the United States with reimbursement strategies and working the logistics and so forth. I really haven't been routinely getting the CT scans on these patients. And I think some of the contemporary technologies we have actually overcome a lot of this guesswork using knuckling strategies, either antegrade, retrograde, a cross-boss catheter in the antegrade direction. These get rid of some of the guesswork, and we can understand that we're in the vessel architecture without necessarily knowing ahead of time with the CT. So I don't know that it adds as much value as we would have guessed maybe 5 years ago.
Excellent, Craig. We'll continue talking through. The game plan is that you and Anu concentrate on the case, get things started, and Samin, teach us some tips and tricks of what we need to do about CTOs.
Absolutely. Now, Anu, actually, maybe ask Anu also that how you want to, actually what Craig said, I have imported that slide from the Jack intervention with the lead article, exactly those 4 points, where to go with the antegrade versus retrograde. That will be the last slide of my presentation, but he has put it excellent way, because those are the thought process should come to our mind when we are dealing with, because this is not a simple CTO. It's a 30-40 millimeter, and there is after it comes out to the bifurcation, it's a totally blunt end. So that we know that you are going to create a lot of antegrade dissection and so be ready with the plan, and the retrograde is one of the plan, whether we go through the epicardial collateral. So Anu, what you plan to do today?
I mean, great point by Craig Thompson, but I would still try I think antegrade first. The same thing, we time every time we start the CTOs and feel for how the cap is. If we have a good feel and we know we're progressing, we continue, otherwise we have a dual access to quickly go to retrograde.
Good. Okay, now with that note, we will start now. Now clearly, as we know, in this day and age, the appropriateness, even CT or so, you come this side. Yeah, that is very, very important, and this we need to put into the grid. So therefore, what we used to do in the past, take care of the unstable lesion and then bring back for the CTO is no longer permitted. So either patient has to be symptomatic on medical therapy, or patient has a positive, they have some functional study, and this patient actually had both. He's on dual antiplatelet therapy, has class 2 angina and has an inferolateral ischemia. So that makes sense that it still fall into U category because it's a single vessel disease. Now the 2 points as we always try to make during our presentation is one is the specialty guide wires and the devices for CTO, and secondly, why should you do the CTO recanalization knowing the vessel is already occluded? Why you should worry about the rationale and technique? The first one is specialty, maybe before Anu starts which wire she is going to use, and I'll ask her to just make a little quick summary of the CTO wires, and of course majority of them are from Ashai and Abbott, whether straight tip or tapered tip, and she can just make it a point, and the new wire, which is the progress wire, which is being evaluated in an ongoing trial of the CTO, which is the expert CTO, and Anu being the lead enroller in the United States with a wide margin. Anu, you want to tell us which wire is your select? How do you go escalation versus go to the final wire technique, and this progress wire issue with the trial ongoing?
Yeah, I think in this case, as well as how we normally approach, you can always go with the glide wires, which have which will be shown, which are the fielder wires. Fielder wire come in regular fielder FC or fielder XT. XT has a tapered tip with the tip of 0.009, the others are not tapered. They are polymer as well as they have a hydrophilic coating. So that you could use to go through this diffusely diseased vessel until you reach your cap. Then the question is how, what kind of technique, which he will show the slide. Initially you can just use a drilling technique to see how far you can go and quickly escalate then to use your other wires, which is the re-entry wire, which are the confianza wires. Again, confianza comes from 9 to 12. If they are they have what is called as a hybrid coating, they are tapered tip. If they go to 0.009 tip and they have a hybrid coating, that could be used for re-entry. Now, if you go to the progress wire, which is what was used in the expert CTO, in the first half of the cases, they wanted us to use this wire. They were trying to get the approval for the use of CTO, which you see here is high torque progress wire. What it is, the core is a transitional-less parabolic core, so that they can be, your one-to-one torque is transmitted up to the tip. And I would say this is a combination of a fielder as well as confianza, in the sense that they have a coating as well except the tip. The tip is tapered, there is no coating at the tip, but the entire, there is polymer as well as some hydrophilic coating, so that you are able to negotiate through all these tough CTOs. And the tip load is probably the highest. There 200 progress goes to about 13.8 gram, whereas it's about 12 gram for your confianza.
Let me ask you one, if I had to tell you that besides fielder, when you bring your over the wire catheter to the total occlusion, if you are allowed to get one wire, what is your favorite CTO wire? And I'll ask that question to Craig also. One CTO wire. Cath lab allowing you only carry one.
I would go with the confianza.
Which one?
With the confianza 9.
9. Confianza Pro 9, correct?
Pilot 200.
Pilot 200, great. Yeah, Pilot actually, a lot of people like the Pilot. We actually had not much experience with the Pilot. We did carry, and of course has been used some as a part of the expert CTO. How far are we in the expert CTO trial?
They have, I think, 198 enrolled. They're still ongoing. Now
how many total cases need to be done roughly?
About 230 cases. 230,
yep. I said. Yep, that basically, but again, it's the not randomized. This is like every device which was approved. You can see here, primal laser, front runner, safe cross, crosser, all they were done 100 plus cases. Just very simple, and that is how FDA approves these devices. Was so simply, and now we get what happened. Most of the catheter on the right side is biting the dust from the interventional perspective. Bridge point with the crossboss and stingray, which has been now taken up by the Boston Scientific, shown by the FAST-CTO study, is the same. It still has some premise, and I'll try to get to that which case it will be most useful. There are a lot of other techniques and devices which are being worked on, and I'm sure the various techniques, whether control, penetration, sliding, are operator's choice. And then many times we have a little extra support, but very important is, which was mentioned, is the retrograde approach. Now, what is retrograde approach? That is, go through the collaterals, whether bypass graft, septal or epicardial. Like this case has a little bit of that AV continuation from the left system, or epicardial, which is basically both are epicardial in this particular case actually, with the bridge collateral of the Kugel, septal very little, no use, and the lastly is the bypass graft. You can see the most of the cases are done at present by the septal, and seems to be the best way compared to epicardial, which have been shown, but does cause more perforation, and of course the much tortuosity and so. And therefore, septal, majority of the retrogrades are done via the septal approach. And of course, we talk about these collateral channels, whether they are zero flow, CC1 or CC2, as shown here. But more important is basically that what is about this retrograde, because that is what we need to know a little more. That is the typically reserved for the LAD or RCA CTOs, although others can be done, and septal collaterals are the best. Avoid using epicardial collaterals for obvious reason I said. And there are 4 techniques. One is the direct retrograde crossing, the kissing wire, control antegrade and retrograde sub-intimal tracking called CART. using either balloon dilatation or the knuckle wire, and the reverse cart is basically means that going little antegrade and dissection, or the last is the limited subintimal tracking. And this actually put very nicely in Jack about the techniques of the kissing wire, basically going through the collateral, then you go in the front with the A, and then your retrograde wire all the way you go, and then of course many times you have to exteriorize the wire, and there is the very stiff wire called Viper, which is a 320 centimeter required for these exchanges. And the cart basically is that you are going retrograde and you are creating a subintimal space to get an antegrade entry, and the reverse cart is you are going antegrade. Particularly the Stingray device is the classical example of the reverse cart, that you are going antegrade, subintimal, and get to the main lumen. And this is the whole concept of the cart, that you are going retrograde subintimal injury and get into the space with the antegrade. And these are the various techniques of the reverse cart which have been described very nicely in the Jack intervention. The question always comes, when to do retrograde technique? And of course, I'll ask Craig to comment on this. What has been in the literature, the recommendation that you should do at least minimum 200 CTO cases antegrade before you go to retrograde, because retrograde is more skill, little more complication, more technique oriented, so you should have a good understanding of the devices and of wires and before you get to the retrograde. Then have to have dedicated setup, equipment, and ability to handle complications. Usually after failed antegrade, once or twice approach, except maybe in a rare case, that is the ostial stump occlusion. Ostial RCA, we had the other day, we could not engage the ostial RCA. We went retrograde, opened up the back entry, and then antegrade wire went very simply. So the ostial stump occlusion. So the Craig, if you have to say, people ask that when do I try retrograde? I know you did mention that some cases you do start retrograde to begin with.
Yeah, I think the first aspect that you had discussed is really the development of the skill set. So if you've done a lot of retrogrades, comfortable with a variety of techniques, I think that's where the strategy that I discussed a little while ago, particularly when there's osteal lesions, there's ambiguity in the proximal cap, there's a bifurcation at the distal cap that's fairly important, and these osteal lesions. These are good anatomic reasons to do retrograde technique, but that's also provided on what the relative skill sets and risk of doing retrograde are in a given case. And I would agree that there needs to be a good fundamental antegrade skill set developed prior to developing retrograde technique, and certainly there are a variety of proctoring programs that allow experts to be available as given operators and programs are developing their skill set. But I think this 100, maybe 200 cases under your belt with antegrade technique is appropriate for and taking retrograde.
Great. And then this is the data from the FAST-CTO which got approval to the cross-boss catheter, which is basically the dilator. So what you're doing basically, the create a subintimal space, then bring the Stingray, and which has a opening at two sides, whether goes to the outside or inside, and your goal is the inside into the lumen, and then of course you change it to the wire Stingray device. As I mentioned that with a reasonable success, although the failed CTOs, it will be successful in about 50–60% of cases, but really it add to your overall success having this into the armamentarium. The second, quickly, because then Anu is getting ready with the technique, and that's the whole the webcast is all about the techniques, that rationale, who should do it. Clearly we know the CTO leads to more cabbage, high syntax score. CTO got a special preference in the syntax analysis, and therefore many patients with the CTOs go for coronary artery bypass surgery. But by and large, even various registry, including Japanese, overall success rate is about 70%. So we say, well, but experts in Japan may be high, but if you take all together, it will be 70–75%. So overall, the CTO is still, by the various technique, based on what it is, really gives the success rate around 70%. So second, this is the Canadian registry, published in Jack intervention this year, that says that about 18% of the angiogram we do have a CTO. But of that, you can see there that only 1/3 are taken care. Therefore means the PCI of the 18% occurs in only 5–6%. And of course, many of them are managed medically or undergo bypass surgery. And key is that even when you attempt, of the 162, success was 123. Again, bringing to about 80% in this large prospective Canadian registry. This is a very important slide. It actually tells you that there is a big regional difference in the treating of the CTOs, because clearly that if you are a center for the referral for the CTO, the PCI CTO, which is in the yellow bar, you can see here that clearly it's a difference in the within Canada where patients are selectively referred. So that clearly there is a regional geographic difference in terms of the CTO. Same thing like Sinai, you know, of the 5,000 cases which we'll do this year, CTO will make around 500. About last calculation we had was 9.4%. We get so many cases referred, as I mentioned, that today will be 6+ CTOs. So the patients failed CTO other places are referred to us for a specific purpose. And this really tells you that you need to put your system in together and dedicated team and clearly the leader for the CTO referral. The question is adverse factors for PCI, CTO should be done, but why? Lower success rate, disappointment, longer cases disrupt your schedule, more radiation exposure, we know that, then more resource utilization. There is a little bit of reimbursement for the physician for the CTO cases, because once you put a modifier 22, but otherwise it's you use more equipment and still the same DRG and so. And minimal incidents but potentially catastrophic complication of thrombus, dissection, perforation, cardiac tamponade, collateral shutoff, side branch occlusion, and of course contrast induced nephropathy, myocardial infarction and urgent CABG. Now this actually puts in that yes, don't think the CTO does not have a complication. Even your successful CTO will have some complication, including dissection, side branch closure and so, as put here with the Canadian registry. The why to do? Because we have shown if you have CTO, you have a bad adverse prognosis, and if you can open it safely, you decrease angina, freedom from subsequent CABG, improved valve function and improvement in event-free survival, some data to show that maybe you improve the overall mortality. The CTO clearly, we have New York State data, the presence of CTO more than one is associated with higher risk adjusted mortality with the bare metal stent with the 2.77, and even with the DES, that CTO of more than one vessel compared to you have unopened 90% lesion, but CTO gives you much more adverse prognosis, largely in my opinion because of the collateral. And acute MI, the clear cut data that if you have residual vessel after your primary PCI, multi-vessel which is CTO versus no CTO, you truly have a big difference in terms of outcome 30 days as well as follow-up. So the CTO really impart a bad prognosis, and of course opening it has been shown to be beneficial. DES is better than BMS, has been shown by various studies, and very important, this is the nice the review article by Moses, actually editorial on the Canadian study that puts the odd ratio on the right side, that majority of the successful CTO improves the overall survival. Now, only issue here is that it's not a random, there is no randomized data to show it improves, but if you put the registry that successful CTO do improve your overall outcome, as you can see here, successful CTO PCI versus unsuccessful. Very important point, if you see here, is that look at this one, successful PTCA, CTO PCI, which is on the bottom, your unsuccessful CTO PCI is on the top, but if you have a non-CTO elective PCI successful, you are in the middle. So basically tells you that if your CTO, the PCI is successful, your long-term mortality is even lower than your non-CTO elective PCI. Very, very important point, so that clearly if you appropriate, CTO should be done, and of course decrease the need for revascularization, and these are the independent predictor which was shown from the registry of the mortality, MI and CABG. Now just to put things together, the technical consideration, as I said, that has to be assessment of the symptoms, target site, viability, and have to go through the Occlusion, that you are not in the I category, that you have gone through your basics, in my opinion, because these are available, they are published nowadays. And of course, then you go with your various views, which will be highlighted by Anu. And this actually coming back to last two slides, and this is from original from Japanese registry, that basically contralateral dual injection is the must, because it has shown to improve the success rate of CTO. Then you try Antegrade approach probably one or twice. How? Single wire, parallel wire, and go to this various wire technique. If you fail, then clearly you'd go to retrograde whether after one failure or second failure, except I would say retrograde in the ostial lesion probably sooner, and rare case of the IVUS guided re-entry, and of course retrograde various techniques which have been shown. And the last slide, which Craig mentioned, he is one of the author in this review, that clearly that what should be the algorithm for crossing CTO and when you switch the strategy, and basically it all depends on that whether you have the ambiguous cap, what is the distal target, how long the lesion is, and really put it together what has been mentioned. And it's a nice algorithm which you guys have put, very nice educational, that for anybody to learn, you know, from the simple to more advanced, that go to step 1, 2, 3, 4, 5, and then you go to 6. If 6 fails, then you switch strategy. So all these have been put in a very nice way in this, elegantly in this article.
Samin, excellent review. Anu, bring us first of all up to speed, because this may be a very long case.
Yeah. Tell us what's happening.
If they can, you can see it now.
Yeah.
Right. So again, guide selection, right coronary artery. The question is same. Always some guide support you need. You could go with the AL 0.75, AL1, or I use the Lima guide only because if you see the proximal RCA, you know if we had gone with AL 0.75, it would be sitting in that diffusely diseased area, which could give us trouble. So Lima catheter, as usually, you know what happens when you reach from, especially because it's a distal RCA, when you know you are reaching the distal portion of the vessel. If you can see that now, it was giving trouble. I always go with the over the wire you know, catheter, which we have is a fine cross. We were able to negotiate just with the fielder and fine cross. I was having some trouble after the second RV branch, but just with the deep breath, we were able to get the fine cross all the way down to where it is, and now I think we need to change the wire.
Anu, let me take the opinion of our in-house expert.
Yeah.
Craig, would you do anything different here?
No, I mean, I think in terms of antegrade approach, you know, fundamentally there are two methods. One would be to use a crossing catheter, crossboss catheter, with an idea that if it didn't cross true lumen, which about 60% of the time it won't, then you could do provisional re-entry. But I think with a wire-based strategy and showing great technique, using I think what seems to be a minor detail, which is very important, is that she's using a microcatheter. So she can switch wires, switch shapes within the lesion very easily without having to re-access that diffuse disease. So over-the-wire microcatheter, and now she's exchanging wires. She recognizes in the lesion, she's probed as long as she can with this soft wire, and it looks like she's stepping. She'll tell you about the wire she's choosing and the shape, but she's changing her strategy in the lesion so she can continue rather to make progress.
Anu, is that a fine cross?
Yeah, that's the fine cross we have. I'm going to change it to the Miracle Bro 6 just to again have a feel of how tough this cap is.
So you don't think you need to go directly to a Confianza here?
No, no.
Okay.
I mean that was the choice given to me if I had one wire.
I
hope I have
but I would have gone with a Confianza Pro just
right.
to
There is a group of people who are even saying that they jump this hoop and proceed straight to the Confianza. Craig, let's go to a few more basic steps.
Yeah, but let's go now. Show what you.
Yeah.
Then she
there are
starts,
two ways of making the curve. I will tell you how I make it. Is just you take it and whatever your needle is, you have to be very. So your tip is very small, has to be very small. If you see the Japanese making it is not even a millimeter, maybe 1.5 millimeter, but they go through this needle introducer and they make a turn at the tip here, but I don't like it because many times it can really bend the tip of the wire. We just do a curve by using the same thing at the tip here, unless Craig, you have any other point to make the tip same, right?
I agree. I usually would put the wire through the introducer so you can make this very short tip, but I think this key of having a tip, making your bend approximately a millimeter or so from the end of the wire is very important because you're working in a potential space. So if you use a broader wire shape like you might for conventional angioplasty, it's much more difficult to have torque control of the wire.
Craig, another very basic question, 8 French 45 centimeter long sheath for every case, or is that overkill?
No, I think it's actually, I like to have, continue to like to have 7 or 8 French on the antegrade limb because it keeps a variety of other options open, such as using an IVUS and a microcatheter in the same guide. It makes trapping technique using balloons to help facilitate exchange of over-the-wire systems much more easily done. But one, you know, particularly if you're primarily a radial operator, is not prohibitive to use 6 French, but you have to recognize that there are relative limitations.
Well, making progress whether we are sub-intimal or I think we look to be in the true lumen there. It went very nicely and easily.
Take a picture. Yep. So now keep talking that how your drill, what penetration, what you're planning to do.
No, this was just a drilling technique. Yeah. You saw how I was doing backward, forward, just you have to just use your thumb and the 2 fingers backward, forward, and you can feel the resistance. And whenever you feel the resistance, pull back and keep going backward, forward. That's why I think that a small tip of that wire actually will help you. The question is the same, never push. The wire will find its way, keep going with a little resistance forward. Now the key is here same to make sure whether this transit catheter will go, same the guide, distal wire has to be in the lumen where you're supposed to be. You may still see few PVCs, not to get too worried.
Craig, customized short guiding catheters in every case, or how are you? You're special ordering them?
I do for the retrograde limb because I'm generally set up on the retrograde side to do a retrograde procedure, even if I'm starting antegrade, and that way if we need to convert, we can do it very easily. For those I have prefabricated 90 centimeter guides. You can shorten guides if you don't have the correct shape or don't have availability in the catheterization lab, simply by snipping the guides and using a sheath, essentially as an interposition unit that's 1 French size smaller than your guide. There's a method for doing that, but it's a lot easier and more stable platform simply to buy them at 90 centimeters. On the antegrade limb, I usually don't, I'll use 100 or 90, just depending on the shape.
Craig, 300 CTOs you do, how many of them are referred to you?
How
much are failures at other sites which are?
I understand. About 60% represent prior attempts. 50 to 60% are prior attempts and failures. Some of those represent referrals that occur within my own group, and the majority of them actually from outside in regional institutions.
Are you able to pinpoint with your vast experience, why do you think the majority of them failed? Was it the inability of the guide wire, or even after the guide wire had crossed not getting a balloon?
It's I think twofold. There's two patterns that I tend to see. One is lack of use of dual catheters. Now in this circumstance, Anna recognized there's very nice ipsilateral collaterals, and if she lost flow, she probably would have put in her second. She has an access here ready for that. But she could visualize where she's going. But oftentimes these collaterals completely coming from the other coronary circulation or from elsewhere, from bypass conduits and so forth. And I see a lot of operators that simply put in a single catheter and don't understand where they're going in the vessel, and that could be easily eliminated by having the second catheter system in.
Anu, you're waiting to show us something?
Yeah, so if you can see, once we have crossed the 2 ways of then going forward, next step to see if this transit catheter will easily go through the total occlusion. Which we had trouble. It was I think first 1/3 it traversed, and then I had a problem. You see the same, the guide is coming out, the wire is coming out despite deep breath. Deep breath is the key in this situation. With all that, it is coming out. So there are 2 ways now. You take out your transit catheter out, and then we discuss the next strategy is either this particular cannot dock, but you can still have a dock extension, keep it straight, take it out, or other one you can do is trapping the wire, which again has been discussed in these papers. What you do is you take your transit catheter out, it's up in the guide, show it, it's there, and now just take a 2.5 balloon for a 6 French catheter. So you are going in the guide catheter without the wire, side by side. So you go all the way till the ostium, dilate it, and then you can take the
inflate.
Inflate.
Yeah. Boston Scientific used to have this trapper. Gone.
Now you can see that balloon coming up.
We see it very nicely.
Good.
And the camera
Go
crew is doing a fantastic job today.
Good. Now you can just take this out.
You'll show that.
Yeah. So now I'm just taking this out. You see that the wire is.
Now you can just wire stabilized, and now what we usually do is, if we are able to advance this over the wire system, just to keep it simple, because you don't push CTO wires, because they can cause perforation of the distally. So then we just change it after crossing. We change it to a Grand Slam long exchange length. Give the balloon. And we just then basically go with your PTCA and so.
So now what's the next step? How can we approach this? Again, two ways you can do is, you can take your smallest balloon that are available in the market to especially use this.
You want 2 or 1.5?
1.25 Sprinter.
Okay.
Those balloon, or you can use the Corsair.
Yeah. But Corsair will be a problem again, because the wire tip will be distal unless you keep it stabilized trap.
Yeah, you can leave that trap balloon there and use a Corsair to go.
Because I just want to say, very important that the distal tip of these CTO wires, could be associated with perforation. So you need to make sure the usual hydrostatic exchange which we do for non-CTO wires should not be done for the CTO, because that wire will go distally and will perforate those small capillary.
Particularly since so many of them have a hydrophilic coating too.
That's it. Yeah, and this is a 1.25
Sprinter.
Sprinter.
Yep. Sprinter Legend, the 6 millimeter.
Craig, would you be doing the same, or a Corsair?
No, I think this is a very reasonable strategy. I mean, certainly a Corsair might be able to penetrate this, but just from a cost containment perspective, since we have a separate microcatheter out now, I think trying the balloon first makes a lot of sense. And it's obviously got great control of this distal wire, which is making most of this look extraordinarily easy, which is fantastic to see. But even, I mean, she's getting as far as she can in the lesion. She probably will dilate at some point where it stops. And dilating, well, I think one of the keys here too is there's so much diffuse disease in the proximal vessel. This oftentimes can constrain the microcatheter and balloon system. So simply dilating within the lesion as far as you can go, dilating all the stenosis back in the proximal vessel, oftentimes can liberate the balloons and microcatheters for next steps.
That is a very important point. Since we were getting stuck in that after the second RV branch, I think it's a tight area there, and that's why it's not letting any of these devices to go further in. Deep breath, sir.
So perfect illustration that once the wire is through, it is not time to open the champagne.
No.
Not yet.
Not yet.
Now, Craig, let me engage your expertise here. Even for cases which are referred to you failed at other institutions, sometimes even you have the humility to approach them as a two-step procedure, and you inform the patient that he may have to come back again for a second attempt.
I do. I think there's some special issues around informed consent for the chronic total occlusions. While the radiation skin dermatitis can happen with any complex intervention, I think we're certainly very sensitive towards this in the CTO community. I try to specifically inform them about this. I inform them that there's probably a slightly higher rate of perforation. In my experience, it's about 1.5% that requires some kind of active therapy, stent grafts, coils, causes termination of the procedures, centesis, and so forth. And I try to inform them of this, and then let them know certainly that success rates, while better than they used to be, are still imperfect, and that failure on one attempt doesn't necessarily preclude coming back for a second attempt.
What's your own personal batting statistics? What percentage come for a second procedure?
Now it's about 5% or so. I have about a 95% success rate.
So the ones coming back almost exclusively you are going retrograde?
For my own failures?
Yes. Or it depends on
it is generally, it is heavily leveraged towards some kind of advanced strategy, whether it's an antegrade re-entry with a stingray balloon or retrograde. But generally, if they've failed, if I've failed them before, I've usually have attempted a variety of things, a la this hybrid technique. So they've had a pretty aggressive attempt, and generally speaking, the follow-up attempts are going to need to be fairly aggressive. This said, is that oftentimes these, particularly with these aggressive attempts where we leave the vessel with extensive dissection and so forth, this can oftentimes heal up advantageously, and you bring them back and you find that they have a channel, and it's a fairly simple angioplasty. Yeah. And we see that probably as often as not, in my experience. Is that what you see?
Yeah, what we say is we leave the artery, we call artery in pieces.
Exactly. We call it an investment procedure for the follow-up.
Anu, what are you doing here now?
Now, same, I think even with the 125 balloon, I could not go. So what we are doing is I have already in the guide is a guide liner to see if the guide liner we can extend the guide and get the device. But more important, I think we are definitely going to dilate that proximal part of the right, which is not letting any device to go further down.
Right. So
and then if in that situation, then we can get the guide liner down. Yeah. Go up.
Craig, would you use something different rather than this mother and child approach?
You saw that there was a tight lesion there.
Yes, I saw that.
Down.
No, I absolutely love this. I mean, I think the only other thought is and I discussed a little while ago, is using a Corsair microcatheter or something along these lines. But I must say, I am a huge fan of the guide liner mother and child approach. I like how she's doing it with the balloon in, dilate, prepare the area, and then I just take the balloon down and typically inflate and anchor that to help facilitate delivery of the guide liner. But I think I consider it it's a fairly simple device. I'm sure any of us in the room wish we would have invented, but
it is a simple one. It's unbelievable how useful, and we have actually repeatedly, time and time, in our these complex cases, we have shown the utility of the guide liner, most important being the last week, last month, remember that totally occluded.
Beautiful tortuous super dominant RCA.
Without the guide liner, we would not have gone a millimeter distally in that distal lesion. And here same, Anu is advancing the balloon and advance the guide liner on the balloon. And that is the key.
Yeah, very important is always pay attention to your tip of the distal wire.
Where is the balloon now?
And the balloon is here.
Yeah.
I went further down.
We dilate a little bit here?
Yeah, dilate.
Yeah, and just coming back to the point of the statistics point of view, as I mentioned that we we have to advance the guide liner a little bit more, and then it will make it.
Not going now.
Huh?
It's not making it.
Pull back again and go back again. Pull back, make sure the wire remains there. Come back in the guide, the balloon, wrap it up and go again. No,
Anu, you think if you had AL 0.75, would that be making a task easier?
Yeah. No, I know. I can tell you AL 0.75, you do it, about 10% you will have a dissection of the proximal area.
Right.
Just because so much disease.
And trauma, yeah.
Yeah, just from the trauma.
No, I'm not trying. I was trying to get the guide liner.
Get the guide liner in. Yeah, and
you can inflate here to anchor it too.
Yeah.
That could help
and
really help you drag it in.
Down.
It's not going. Let's not push it.
Yeah, I know, but here, trying to bring the guide liner more, it will help you further down.
Going.
Now guide liner advance. Yeah.
Craig, on the topic of radiation, another critical concern, are you having a radiation monitor installed in your cath lab and you monitor it in every case?
We do, and we have call outs for every gray and air kerma that we go up. Generally speaking, I have my personal threshold is to call a procedure depending on the strength of indication, but my general range is about 5 gray is where I really think about changing the strategy, not changing the strategy, but terminating the procedure.
Right.
If we're not across the lesion and simply performing angioplasty at that point, occasionally depending on the real strength of indication, I might, and how well I'm able to spread the radiation around with different angles and so forth, that threshold may be higher up in the 7.5 range. But I think we like to have even with a case that you could spread radiation, use a variety of angles.
Well, that's also important as a general rule to avoid the steep angles for the cumulative
air karma, yeah. And actually now, in those who have our cath report, we put at fluoroscopy time, the air karma and the dose area product depth.
Okay. Now if you see it, the balloon went through there.
Wire a little too far?
Yeah, I'm going to pull the wire back. I think that was the proximal lesion was not letting this catheter go further down.
Would you get a 2O balloon? We are ready.
Now
there.
2O balloon, yeah. Or even the 2.5 you may go.
Craig, has Corsair been somewhat of a game changer for CTO success?
Oh, I think absolutely. I mean, it's certainly a huge game changer, or effectively a revolutionary device in the context of retrograde techniques.
100%
And I must say, it's actually a fine antegrade microcatheter, much like the fine cross was excellent for this case as well. But it has it's very nice to support wires, and is also good for difficult lesion crossing, such as the situation that we're dealing with now. So I think it's been a very effective part of the toolkit.
How often and when are you using IVUS for mainly for the retrogrades?
Probably in the 20% range now. I used to IVUS virtually everything, and I think it was very useful, particularly during my learning curve, to understand how I was crossing lesions, to better learn how to size vessels for reverse cart type maneuvers, and also to learn how to size vessels that appear to be hypoplastic but in fact just don't have adequate flow. That said, I generally am not using it universally now, but most often am using it in the context of retrogrades in cases where I've done an adequate balloon, what I feel is an adequate balloon inflation given the size of the vessel, and I'm unable to connect the channels. I think that's a very good reason to put the IVUS catheter in on the antegrade wire and to try to understand what the mode of failure is and to figure out the next best strategy to overcome this.
Yeah, and the question is always the point which has been highlighted, that CTO, when we talk to the family, and so it has to be. Now you can see there is a flow Antegrade. Now we are trying to see that what to do. Can we put another wire side by side, which is our run through? If can go through, we take other things out, dilate, and then put probably 2 stents. And that's what being done, because clearly it will require a little push and pull of the existing wire may be associated with this little perforation. So very careful on that issue. So that first thing, when the balloon crosses in our lab, we have said that you need to now change your wire. Yeah, like here in this particular case, you can go further. Actually, there is a large
So your second wire here is
the run through.
No, I understand, but the principle here is more of a buddy wire rather than a parallel kind of a wire, and just to give yourself a less stiffer wire.
Yeah, exactly. Yeah, and more important, to avoid the distal
perforation.
Puncture. Yeah, distal
exactly
perforation.
Right.
Now, question is, you think you went through it? We don't know whether wire is through the guideliner or not. That's the only issue remain. But anyway, this is a 2.5 balloon, or what is this? 2 or 20. You want to go 2.5 or 2 or 20? We have it 2 or 20.
Craig, almost eliminated now with the use of Corsair, almost eliminated Tornus, or do you still use it sometimes?
Still use Tornus sometimes, used it yesterday in fact, but it's a much smaller percentage of the cases than I used to. And particularly with the variety of re-entry strategies, both in the antegrade and retrograde direction, oftentimes using those methods, you bypass a lot of resistant lesions because you're going around on the outside. So actually stent device delivery can be a little more easily accomplished. But I still probably use Tornus maybe 5%, certainly under 10% of the cases, but still a noticeable amount. There's often times where Tornus will cross or engage a lesion where Corsair will not, and vice versa.
Yeah, we actually have eliminated tornus completely because of same. Because clearly that use a fine cross and the Corsair, because again otherwise yes, in rare cases you may need it, but just to say from the lab point of view, we have eliminated tornus now by the 6 or 7 French.
Craig, always unfractionated heparin as a rule, or some cases of bivalirudin?
Typically, for me, it's unfractionated heparin unless they have heparin-induced antibodies and so forth.
ACT 300 or 350?
Generally, particularly for retrograde procedures, I try to push it closer to 350. I think the issue of donor vessel thrombosis when you have multiple catheters in it can be a really devastating problem. So I think I think being very cognizant of ACT issues throughout the case and having a process where this is monitored is extremely important.
I'm sure almost every CTO ends up having a DES. Any preference to a particular DES for CTOs?
I don't have a particular preference. I mean, there are relative minor merits to the conventional DES platforms. I think what I feel more strongly about is the
Craig,
conventional era.
Yeah, 1 second, Craig. Anu, things looking wonderful there.
Yeah, we are just trying to get the stent ready. We went with the 125 was the initial balloon, and then we went with a 2O balloon. Hopefully the stent we should be able to long stent. Right now we have 28, 30, and 38 millimeter stents.
Craig, continue with your thoughts. Sorry, I thought might as well the viewers to bring them up to speed.
This is a fantastic. Now question is, do you prepare further or just put a stent now, give a 3/30 resolute now?
Coming to the anticoagulation strategy which you mentioned, actually in Mount Sinai Cath Lab for the last, I would say ever since we started using Angiomax, which was 4 years ago, we do every CTO with the bivalirudin. We keep same with the ACT just about 300, maybe slightly higher if you are doing a retrograde, because when you are doing retrograde, the most important I think devastating complication is the thrombus of the other vessel.
You favorably use the short half-life of bivalirudin to compensate for any perforation?
100%. You see any wire perforation, what we call is a smoke. The wire has gone here, there, a little, what we see, start seeing smoke, a little hematoma, just stop it, go for a break, do something else in another room. When you come back, everything is good, just keep going.
Yeah, I must say that I think the issue about using unfractionated so that you can use protamine is probably an overstated situation, because any real bleed that you have in the cath lab, you're effectively going to have to actively manage during these kinds of cases. It's not going to be a protamine situation. You're going to be coiling or putting in a stent graft or maybe a little bit of a balloon inflation. So, while I think the last time I said I haven't used protamine in a few years, I used protamine the next day, is that I don't think that should be a very important driver. I know some people have concerns with prolonged cases that you may have a more disposition towards a guide catheter thrombosis, but frankly I think if you manage it very actively, there's probably equipoise between the anticoagulants.
Craig, take us through some other very pragmatic day-to-day issues. As an example, at how late in the night after which you will not schedule a CTO or start a CTO?
Well, I
think you can't predict. No, really. Some of these cases will take you many hours.
I'll tell you I think the real key issue there is that I try to, unless there is a really strong clinical driver, is I try not to do CTO cases ad hoc. So I think aside from that, I think the answer to your question is I would only be doing CTO cases when I feel like I'm completely intellectually engaged in the case. So if it's late at night, then I need to make sure that I'm mentally prepared for what I need to do. I mean, what you don't want to do is be in a situation where you feel like you have to take shortcuts, because there's nothing that can prolong a procedure than taking a shortcut oftentimes.
I think a very understated point is both patient and operator fatigue in some of these long cases, and I think it's so critical to be sure that you have managed your personal commitments before you engage in one of these long procedures.
I think that's very wise.
Very, very important. Other day, when was it? Just actually on the Friday, based on our cath lab schedule, we started 2-room CTO. One was at 10:30, other one was at 11 p.m. The way it just worked out because of the cases. I'm actually trying to make many of the elective patients to come at 9 p.m. We say have a dinner and then come for PCI.
Yeah,
Sleep here and go back for the breakfast.
They used to watch a movie instead of that before. Craig, what part of your CTOs are transradial?
You know, I do a mixed approach because 90% of my cases are 2 catheter cases, and generally speaking, I'm a default radial operator for conventional angioplasty. So I have been typically setting up the retrograde limb transradial. I think that 6 French, or you can even go 7, but I think that 6 French is generally adequate for that. And I will usually set up my antegrade limb 8 French transfemoral. So I'll have a femoral and a radial on the majority of my cases. Occasionally, for a variety of reasons, whether it's access or if somebody's traveling from overseas, maybe I'll go biradial. I haven't switched to doing that routinely now because I still, for people that can tolerate 8 French transfemoral, I still enjoy a lot of the advantages of having a larger guide catheter.
What's your preferred agent, ADP blocker post-procedure? Moving more cases to ticagrelor?
Not really. I'm, you know, I think like many of us around the country, I am struggling with the variety of new agents that we have aboard now. We still default to Plavix. We are triaging patients to the other antiplatelet agents. At this point, still largely on the basis of antiplatelet assays, though I think one could very strongly argue that the clinical situation, like a CTO or a bifurcation, is probably a smarter and better driver for that than is measurements of antiplatelet activity.
The point on that, the strong antiplatelet therapy, any patient who is coming for CTO, we try to avoid using a stronger antiplatelet agent because of the risk of perforation. We actually had few cases who are on efficient LAD and so forth, and more microperforation, more smoke, and so we try to avoid that portion. So coming back to the point, and I think let's bring it back to the closure. You can see here, angiography, everybody sees it?
Looks beautiful.
Yeah, we just had to do a little post dilatation maybe.
I mean, what about just before the, in fact, you're happy with how it looks after the bifurcation? Or
yeah, no, it's a little bit
That's
dizzy.
If you see your initial angiogram, you can see it. There was an
Diffuse
ectatic
disease.
area to begin with.
Right.
We didn't want to go, cover the PDA. We
because
just
you can make it a case a little more complex. You can cover it, then go through, because there will be a lot of plaque shift into that. See the angulated PDA. You'll have a plaque shift. You have to go through it so that it's better. And what I do is many of these cases bring back in 4 or 5 months for just a quick check, an angiogram, and if you need to be a little touch up at that time, you can do it.
You won't trust CT angio for that, or?
Well, I mean, again, CT angio, in my opinion, overreads it. Native, non-calcific, but native vessel, I think is very good. Post-stent, we are not very, I have seen both ways, good and bad. But clearly that this is just the point of what has been done.
30.
And we'll just post dilate here with the 30 long balloon. Stent should be always post dilated. We carry 30 millimeter because most of our stents are longer. So we carry 2.5, 30, 3.25, 3.5. What is it?
Craig, thoughts on any preference for CTOs for a radio contrast agent, and what would be your absolute volume of dye beyond which you will not proceed?
I don't believe there's any substantial differences, at least based on the most recent rounds of clinical trials between the contrast agents, so I don't feel really strongly, and just use whatever is the convention for the lab that I'm working in. In terms of contrast limits, I would generally calculate that based on MD-RD equation or other assessment of GFR, and just establish a limit ahead of time. And again, I might,
which is about 5 ml per kilogram.
Right.
So that, 60 kilo, 70 kilo, you're giving 300, we should not go beyond. And that actually has shown itself as an independent predictor of contrast nephropathy virus.
Craig, you and Samin both have a busy interventional fellows training program. What are some of the basics or even some rules you've made? When does a fellow start doing anything retrograde?
In the context of our training program, I work with them and let them work with me on retrograde cases. I mean, for thus far, at this point of the year, the interventional fellows haven't done a lot of retrograde wire work because they need to become a little more versed and comfortable with standard wire manipulation and angioplasty skills. As the year progresses, because they're in a supervised setting with me, I would have them start developing retrograde skills, including collateral vessel wiring, retrograde lesion wiring, and performing reverse cart, because it's a highly structured and monitored environment. And that's a little bit of a different scenario than someone that is out in practice trying to develop their own independent skill sets and programs that encompasses retrograde approach.
Looking into the future, what are some of the promising CTO innovations occurring?
I think there are a few interesting technologies that are out there. One of which is forward-looking intravascular ultrasound. That the active and most developed program is with Volcano Therapeutics right now. We're currently doing a first-in-man trial in lower extremities with this device, and then hopefully we'll have a device that's more scaled and testable in the coronary circulation sometime, perhaps even within this coming year. And I think that can be particularly helpful, not necessarily using the device to image as you're moving forward through the total occlusions, but to help work around this ambiguous proximal cap issue, which I think is probably the major limiter for a more broad-based use of antegrade approach. So my sense is that if forward-looking ultrasound plays out, that it'll help facilitate more antegrade procedures and lead to a bit of a reduction in retrograde procedures in the otherwise complex environment, because we have ways to work out the rest if you can get into the lesion safely.
Excellent. Anu, skin-to-skin case with the complete arterial reconstruction in 59 minutes.
And ready to take a picture. Let's take a ready to take the picture.
Gorgeous.
All
Absolutely
right.
Beautiful result.
Nice.
Good.
Very nice.
Okay, let me sum it up very quickly now. The last hour point take-home message. Rationale for CTO revascularization. Successful CTO recanalization where appropriate has shown to improve long-term MACE, lower need for cabbage, and probably decrease mortality, although I may not buy it completely, but registry data supports it. Second, appropriate revascularization technique is highly operator dependent and needs to be adopted based on the operator's experience and the dedicated centers with well-established protocols and equipment use. And clearly the two-step, just like we say that you get a booster for immunization. So the patient come with a CTO, make sure that they could come for the second time, because that is what our data has been shown also, that we have about 80% success time 0, and then they come back many times it's recanalized by itself, about 16% on top. So all cases referred, about 96% success rate in last 1.5 years, because we added the retrograde in the rare cases where we failed antegrade twice. And that really has done about 500-600 CTO cases with an excellent track record, and will continue. Coming back to the final 3 questions which we need to do, because we're getting ready for our ACC, will be the CME certification starting 1 hour CME credit starting January, so that we'll have the question and answer. People have to go through the login, and then answer the question and get after answering those 3 questions, I have the explanation, and then of course they get a 1 hour credit. The following are the technique of retrograde recanalization except cart, kissing wire, reverse cart, and IVUS guidance. With clearly the answer should be simple, which we have gone through. Second, successful recanalization of CTO has shown to reduce following events except angina symptoms, TVR cabbage, stent thrombosis, and mortality. And lastly, the incidence of CTO and coronary angiography has been reported to be the less than 10%, 10 to 20%, 20 to 30%, and more than 30%. So those are the 3 questions. And with that note, with a beautiful demonstration of the CTO, likely will have a case next month also of the CTO, but we will always want to find a appropriate case, able to do. Clearly many of these retrograde cases may take a couple of hours and you may not be able to do in 1 hour. So we have to have case which is suitable for 1 hour recanalization, and we expect to do, as I mentioned, a few more CTOs going forward.
Anu, tell me in your summary mainly what attributed to your success in this particular case. What did you think which really defined it?
Or overall, actually within our group, that cases by many other attendings, remember in the in our June symposium, when she was doing this retrograde CTO, and the Colombo's comment was the right one. He said, you know what, I'm too old for this CTO, I give it to my young partners. The same thing here, that expertise and the dedication will lead to, and I'm sure of the 600, 500, 600 CTO, 90% will be done by Anu in our lab. And clearly during that time, the lights are down, no phone calls, and just concentrate. Yeah.
Yeah, if I say if I can get 15-20 minutes of my time away from this complexity of the lab, and this is the room dedicated so that you see nobody can, the way the room is made, that nobody can come and bother. I think what exactly is concentration and how to get this selection of the cases, as well as how most important I would say is the skill set that you keep developing and challenge yourself, that how to get success with these complex cases, and I think that is how been able to, and I would say a lot of it could be with Angiomax. Since we started using Angiomax and we started having this initial little perforations, and I realized that you stop Angiomax, wait few minutes, and you are able to keep going through, compared to our Japanese colleagues, where we know that they become very aggressive, even put pericardial catheters and keep going, which we cannot do in the United States. So I think with that has led us to go to the next level of challenging ourselves and taking on all the tough cases.
And avoid effuent and brillianta in these cases.
Yeah,
very
that's
important
other important point I have to make is this particular patient would be otherwise an excellent case. Young guy presented with a non-QAMI should have been on effuent or brillianta. And once I see CTO, you should never be on those strong antiplatelet therapy. That 2 cases that I have done, one was on effuent, another one was on brillianta.
So Anu, just to quickly correct you, it has to be prasugrel and ticagrelor.
Okay. Prasugrel and ticagrelor. If they are on those medication, what happens is even simple perforation, that micro perforation that we normally see that heals quickly, it does not happen with those strong antiplatelet medication. And in one case, we actually had to stop the procedure. So once we know that they are on those strong antiplatelet therapy, that's the time I think we should consider twice before you become very aggressive with these wires.
Craig, it's been honor and privilege having you join us. Final thoughts from you?
Well, I think this was just a fantastic case demonstration. I think you had asked Anna what the most important contributor for success was here, and it's the skill of the operator, skill and experience of the operator, and she showed a fantastic technique. So it's a delight to be here and join you for this live case.
It's been an honor. Just for our viewers, please tune in November 28th for Dr. Krishnan and Dangus to take you through peripheral interventions. Our next session is December 18th. Samin, final thoughts before we close?
Well, it's just basically our goal, the mission of the live web series, give you the all technical tips, and we'll continue to propagate that and teach everyone, the share our tips and tricks, which people say that many cath labs will be envious of it. No, I will be proud that people are able to do what we are doing and get the similar results as shown by the New York State consistently, our superb results.
Sameen, I forgot to mention also on a little solemn note, we lost a wonderful and a dear colleague, Dr. Haridas in India. Our condolences to the family and a very happy Thanksgiving to you all.
Okay, thank you. Okay, everyone. Good.